Hello everyone, welcome to the Foolproof Mastery podcast. I'm Patrick Reiserov, and this is the space where I share evidence-based information on plant-based nutrition, fitness, health, learning, and other areas of science, as well as self-development in all forms possible through interviews with the world's leading experts and scientists. Listen to learn how to develop yourself physically and mentally in the most foolproof way. I have an undergraduate degree in chemical engineering, and I am currently pursuing a master's in food science, health and nutrition. This podcast was born from my passion for self-development and being able to break down the latest science to the public. I find it a shame that scientists often don't have the time to share their findings, whilst also losing out to misinformation on social media. What's the point of having science if we don't make it practical? Hello everyone, welcome back. Today I have the honor of interviewing Dr. Thomas Dayspring, one of the leading experts in lipids, fats and cholesterol. So Thomas finished his degree 50 years ago and practiced medicine in New Jersey for 37 years. He's a fellow of both the American College of Physicians and the National Lipid Association, and is certified in internal medicine and clinical lipidology. So Thomas is one of the few people who has managed to go mainstream in the world of lipids. He's got over 20,000 followers on Twitter. He's given over 4,000 domestic and international lectures, and he's listed on the Guide to America's Top Physicians. He's also on the editorial board of the Journal of Clinical Lipidology. Dr. Tom has authored several manuscripts and lipid textbook chapters and performed several podcasts. So I've listened to a few of these. He's got a 7-hour podcast on the Drive podcast, which I've almost managed to get through. And I also listened to his other podcast on the Wellness Fact or Fiction podcast, which was a little bit shorter. So a little bit of a couple nice facts about Tom. He originally wanted to be a fireman, and unfortunately that didn't quite work out, but he likes to apply his philosophy that it's better to fix the house than get rid of the fire. And he's also a big ice hockey fan. And I believe in one of the podcasts, he mentioned that his son was even sleeping with an ice hockey puck or whatever it's called. So, Tom, did I miss anything important out in the introduction?
No, that's plenty. You didn't mention any of my dark secrets, so that's good.
Okay, that's good to hear.
So, yeah, look, my father was a fireman. So, of course, growing up as a fireman's son, that's what I really wanted. But Dad sort of, no, you're going to college and studying something else. And here I am, wound up in medicine.
So, what's really interesting for me to hear, I haven't heard it on any of the other podcasts. So why lipids? What made you get into this?
Kind of interesting. Remember, my med school years was, I call the dark ages, 1968 to 72. And they didn't know a heck of a lot about lipids back then. The only metric that was being measured was total cholesterol. And there was nothing to do, even if it came back high anyway. So lipids were kind of irrelevant at that time. Very interesting, though, in the first year of medical school, in the biochemistry course, they assign a term paper to each student. And I got assigned something called, hey, write a paper on A-beta lipoproteinemia. Of course, I had no idea what that was. It turns out it's people who don't make the ApoB-containing lipoproteins, and obviously there are potential consequences to that. But that was the first thing I ever heard about lipids or did a little bit of reading on it. After that, I passed the course. I paid no attention to lipids, graduated, became an internal medicine resident, but there was still no serious lipid testing or lipid therapies from 1972 to 75, which were those years. But for sure, the thing that kept an internal medicine resident was so busy was the amazing, terrible incidence of acute coronary syndromes, myocardial infarctions, pulmonary edema. We saw them night and day. And if you were on call on a given night, you had 3-4 acute MI admissions. So, and basically back in those eras, we gave them oxygen, we gave them bed rest, but there was not much else we could offer them. So a lot of people died. unfortunately, and many of them young, and of course, both genders. In 1975, I went into private practice of internal medicine in a group of 4 physicians. So you're on call every 4th night. And back in that era, your phone would ring during the night. You'd have to return to the hospital because there was always a patient who was now your patient being admitted with an acute MI. So I learned early on that, God, we have to be able to do better with this disease or I'll never sleep the rest of my life because I'm always at the hospital. So I became very interested. We got to prevent atherosclerotic disease, these MIs. At that time, the only sort of therapies we had was, hey, don't smoke, try and eat a little better, although we didn't know what diet to advise, and let's control your blood pressure real well. And we did have several blood pressure medications at that time. Thank God no longer available because they had multiple side effects, but at least we could do something for hypertension. But I kept thinking, all right, hypertension control is good, but we're still seeing so much atherosclerotic disease, morbidity and mortality. There's got to be more to it. So in the 1980s, all of a sudden, trials started to appear showing the importance of cholesterol. And that first trial was actually published in 1984 showing if you use a drug, it will lower cholesterol and you will reduce heart attacks. That drug was the bile acid sequestrant cholestyramine, which is rarely used anymore. But that was the first drug to give us hope that, if we understand lipids better and we can improve patients' lipid profiles, that's going to be another piece of the puzzle. And of course, following soon after that, in came a couple of trials with gemfibrozole, the fibrate, as a monotherapy, the Helsinki Heart Trial, the VA HIT trial, where gemfibrozole reduced coronary atherothrombotic events. So there was hope. And I just said to myself, all right, you really have to know a heck of a lot more about lipids than were ever taught to you if you're going to be on the cutting edge of lipid science and lipid therapies. Statins, of course, appeared in 1987 with no evidence that they reduced heart attacks, but hey, they do lower various cholesterol metrics. So I just started studying like crazy. There were no standard lipid textbooks back then. So you really had to delve into the literature and start going to journals that most internists don't even know exist, never mind go to. But you'd pull down and you'd start understanding lipid basics and lipoproteins. Half of the stuff I was reading, I didn't even have the knowledge, the vocabulary to understand what I was reading. But it's like anything else. If you keep reading and you keep studying, all of a sudden it starts to make a little bit more sense. So by 1994, the statins finally published their outcome data. The first was simvastatin in the 4S trial that, hey, if you take people with high cholesterol metrics and you put them on this statin, they have significantly less heart attacks. So, of course, I really had to start studying even more about statins, pharmacokinetics, and tying it in with the lipid metrics that were at least available to us in the real world. And because of my very hard study and mastering this, I somehow developed the ability to take what I know and talk to other clinicians and let them know so they don't have to read lipid texts or journals for 3-4 years to understand this. I could sort of break down what they really had to know. In that process, you teach a little bit more about biochemistry than most doctors know, and you get into pharmacology more. Now, over the next 30 years, of course, the world started to explode with cardiovascular trials. Our knowledge of how lipids are trafficked in plasma, our lipoprotein knowledge, how they're synthesized and catabolized, how they deliver lipids to the artery, just was logarithmic, the explosion in data, as was the appearance of subsequent drugs. After all the statins, then along came ezetimibe, the cholesterol absorption blocker, different types of fibrates. And of course, after that, additional drugs came down. So it's just been a little evolution because I was not sleeping enough on my on-call nights, and I love sleep, that I said, the only way I'm going to sleep is master blood pressure and master lipids. And it is kind of funny because after that, I guess in the mid-1990s, all of a sudden in our practice, where I was very aggressive, the incidence of those acute events drastically dropped. And so anecdotally, it was obvious to me that management of lipids and blood pressure, please no smoking, those people would do better. And I think the clinical trials have all proved what I discovered anecdotally, just in a desire that I could sleep better if I ever mastered this. So that's the long story. And my ability to both teach this and explain it, and I also developed an incredible ability to illustrate these talks. I'm a PowerPoint master. Most people think my slides are among the best in the world. Even now I post them on Twitter, but if you were seeing me in person, my slides are animated. So lipids and lipoproteins are sort of moving all over the place and really help somebody master this topic. So because of my ability to dumb it down and illustrate it, I became an unbelievably requested lipid educator. So I went from a good little internist in New Jersey who was minding his own business to just about the most requested lipid educator in the United States. And if you do that long enough, higher ups know you, and all of a sudden, geez, they want me in this country or that country. So it was no grand design of mine to become this sort of enjoyed, respected lipid educator. You know, as the talks have died down for a variety of reasons, regulatory reasons over the years, social media developed that was non-existent in my early years. And as you mentioned, I'd probably interact and get on Twitter way than if you took all my decades of teaching. I probably reach more people with one tweet nowadays than I ever did flying all over the world. So that's my story. I love lipids. I have a passion for it. I can even talk to high-level lipidologists and give them better insight, or I could talk to the guy walking down the street and teach him lipids. So I call it a gift from God or whoever that somehow I can explain this. My father, who was a fireman, as I said, was a very well-educated man with an incredible vocabulary, a well-requested speaker at the type of events he did, which were all fire department related or city related where he worked. But so I got some genes that certainly make me communicate better. So here I am with you today.
Well, thanks for joining. I feel humbled that you are here today with me, and illustrations are great. I completely agree. The mind seems to learn much better when we can visualize. And Peter calls you the mentor of mentors for lipidologists. So that's quite a title to have. So let's maybe go back to the basics then. So lipoproteins, what is the main use of them? Why does the liver produce VLDL? Is it to deliver energy or is it to deliver cholesterol?
All right, so understanding lipoproteins is the absolute key to understanding atherosclerosis and then trying to modify it or reduce its incidence. Because I always, virtually every podcast, start off by telling people, with this terrible disease, the leading cause of morbidity and mortality in the world nowadays, atherosclerotic cardiovascular disease, there's only one sine qua non. You must have cholesterol in your artery wall. If you have people who have no cholesterol deposits in their artery wall, they do not meet the definition of having atherosclerosis. They don't have it. So it comes down to figuring out, why do some people have cholesterol in their artery walls and others either don't or they don't get it till very late in life? So how in the world does cholesterol get into the artery wall? And cholesterol excess is toxic to any cell in your body, including your arterial wall. A little aside, cholesterol is an absolute essential molecule. There would be no animal life without cholesterol, certainly not in the higher animal kingdoms. So it was absolutely necessary for evolution to make sure every cell in the human body had the de novo power to synthesize cholesterol. And also, as a backup, our intestine had the ability to absorb any cholesterol that was in our intestinal tract. So evolution gave us two serious sources of cholesterol, because evolution knows if you didn't have a source of cholesterol, you won't even survive in utero, and certainly will have all sorts of issues when you're a little child or an adult. Now, the interesting thing, so every cell in your body makes cholesterol. Brain cells, you name the tissue you're interested in, every cell in that organ can de novo synthesize cholesterol, because cholesterol's primary purpose in the cells is it's an integral part of the cell membranes of every cell. And cell membranes are the barriers surrounding cells, and membranes regulate what gets into or what gets out of a cell. So any important nutrient has to pass through a cell membrane. Any toxic metabolite in a cell has to be effluxed through the cell membrane. And the cholesterol content of a cell membrane is very, very crucial to its integrity and its function. So cholesterol, all the cells can make it. However, here's the bad news with cholesterol. Of course, in the artery wall, you don't want it, but you do not want cholesterol excess in any cell in your body, because believe it or not, above a physiologic threshold, cholesterol is an incredibly toxic molecule, because like other molecules such as uric acid, cholesterol has the ability to crystallize. Cholesterol crystallizes, causes apoptosis, cell death. So any cell that has too much cholesterol beyond its physiologic need, the cholesterol will crystallize and that cell will die. Now, evolution know this. So evolution said, all right, we absolutely have to give every cell the power to synthesize cholesterol, but at a certain point, we have to give every cell in the body the ability to efflux, meaning make cholesterol exit from the cell. So if cholesterol is in excess in any cell of your body and that cell tries to get rid of it, it has to evict it through the cell membrane. But here's the problem. Cholesterol is in the lipid category of organic molecules. Lipids are defined as molecules that are not soluble in water. You know, fats and oils can't circulate in water, they float. So cells just couldn't evict cholesterol into the plasma, which is basically the fluids that transport so many things throughout our body, because cholesterol is not soluble in plasma, which is a water or aqueous solution, as we call it. So if a cell is going to efflux cholesterol, and there are several specific transporters that can do that, take cholesterol from a cell, efflux it, but it has to efflux it into what we call a cholesterol acceptor. So how do you take an oil, a hydrophobic substance that hates water, what can you stick it on so it can circulate easily in water or plasma? Proteins. Proteins are immensely water soluble. So if a cell takes extra cholesterol and it effluxes it out through a specific efflux transporter, if you have the right type of protein floating around, the cholesterol can jump right on it. So wait a minute, if I take a lipid like cholesterol and I attach it to a protein, that would be something that's carrying lipids and a protein, a lipoprotein. So lipoproteins evolved to traffic hydrophobic water-hating lipids through our plasma to then take it to where those lipids are needed or can be catabolized. So lipoproteins are sort of the dump trucks that traffic lipids through our body, bringing them to where they're needed, or at the end of the day, if nobody needs them, bring them back to basically the only two organs that can evict cholesterol from the body, and that would be the liver or the small intestine. So ultimately, if you have the wrong type of lipoprotein, some of them have the ability to leave plasma and crash your artery wall. If they do that, that's like a foreign substance invading a different country. It's going to cause pathology. So the lipoprotein carrying cholesterol sticks to the tissue in the arterial wall. It's basically recognized as an invader. So our immune system goes to work and sends white blood cells over. Oh my God, destroy that ApoB or LDL particle. Those are the particles that dump most of the cholesterol in the artery wall. And the white blood cell just engulfs that lipoprotein and its cholesterol. Now, if that is doing that continuously, second after second, minute after minute, sooner or later, that white cell, they're called macrophages at this stage, will fill up with cholesterol. It becomes a sterile, a lipid-laden leukocyte macrophage, and we give them the name foam cells. In 1904, the great Russian scientist, medical student at the time, described by looking at rabbits under the microscope. What are these foamy collections in the rabbit's arterial wall after he fed the rabbits cholesterol for a few weeks? And he was the discoverer of foam cells. He was basically ignored. That was definitely a Nobel Prize winning discovery, but it had no use to real world doctors at the time because nobody knew the relationship or could measure cholesterol anyway. But that's how long this concept has been known. And obviously, if you're creating these foam cells over time, you create bazillions of them. They stick together. And before you know it, you have organized collections of cholesterol in the artery wall, initially called fatty streaks, which we know appear, unfortunately, in some kids by the time they're 4 and 5 years old. But over the decades, these collections get bigger and bigger, become more structured, they get inflamed, smooth muscle cells surround them. And before you know it, you have plaques full of cholesterol in your artery wall. If you don't arrest that process, those plaques keep getting bigger, expanding. And sooner or later, they're too big for the artery wall. So the artery, it starts encroaching into the lumen of the artery, which of course would narrow blood flow through the artery. You can narrow arteries down a lot before you cause what is called ischemia, lack of blood flow, lack of oxygen delivery to tissues. But once you obstruct or occlude an artery enough, blood, especially in the small arteries of your heart or blood or brain, the oxygen and other components of the plasma don't get through. The tissues that are supposed to be receiving this oxygen-enriched blood don't. That's called ischemia. And of course, the myocardium doesn't function well if ischemia is occurring. The patient then might start to get chest pain, shortness of breath, and arrhythmia. But sooner or later, if nothing is done, that artery will totally occlude. Now no blood gets through. That tissue that should be receiving it dies. That's a myocardial infarction. If it happens in your brain, it's a brain infarction, a stroke. So over many years, of course, invasive type of cardiologists and surgeons have figured out, we can de-obstruct the artery, and that became a temporary solution, still used in certain cases. But it should be obvious to a listener that, God, if what he's saying is true, if we could just stop the cholesterol deposition in the artery wall very early in life, we wouldn't need bypass surgeons. We wouldn't need invasive cardiologists because nobody would be getting this plaque that is ultimately going to cause the pathology. So we have to have a high understanding of which lipoproteins have the ability to leave plasma and enter the artery wall, which do not. And if so, what metric in the laboratory that if I check would tell me this is a person in whom that invasion of the artery wall is happening or not. And we do have those tests. So that was a long-winded answer on how cholesterol gets into your artery wall and why lipoproteins are the key thing you have to understand. It's going back to my first year in medical school. Remember that paper I did, A-beta lipoproteinemia. So even back then, they knew lipoproteins were pretty important to this process. I had to study people who didn't make a certain type of lipoprotein. That's rare. In our world today, it's almost all our patients make too many of the wrong type of lipoprotein, or they can't clear them when they become in excess. That's enough to answer that question.
So you said every cell in the body makes these, cholesterol.
Cholesterol.
So the liver, does it make LDL or VLDL? Is that like a backup for in cases when the body is under stress and it cannot have enough of its own cholesterol via production in the cells? Why does the liver produce cholesterol?
Yeah. So first of all, the lipoproteins that carry lipids, there's two organs in the body that can construct Denovo, a protein that can attach to lipids and then leave that organ and go circulate with those lipids. Or those lipoproteins that are already floating around, if they are the acceptors of cholesterol that cells are trying to get rid of, those lipoproteins can then return their cholesterol to two organs, the intestine, the small intestine, and the liver. So, but the liver is a key, as you said. Now, Can the liver synthesize cholesterol de novo? Yes, it can, but every cell in your body can. So if you want to know the organ system in your body that synthesizes the most cholesterol, it's the brain. Cholesterol is the total most essential molecule for our neurons to function. Many other things are necessary too, but cholesterol is so crucial. But here's the paradox. Oh, and there's a reason why the brain synthesizes cholesterol, because it cannot get it from any source. Where do we measure cholesterol in our patients? In lipoproteins floating in the blood, total cholesterol, LDL cholesterol, HDL cholesterol. No lipoproteins can leave plasma, cross the blood-brain barrier and say, hey, brain, here's some cholesterol for you. So the brain is denied a source of lipids that every other cell in your body has, lipoprotein delivery. So the brain, thank God, is a cholesterol synthesis machine. And just to maybe extrapolate on that disciple of lipidology, the half-life of a cholesterol molecule floating in your blood, in the bloodstream, is 2 to 5 days. If a brain synthesizes a cholesterol molecule, do you know what its half-life is? 6 months to 5 years. So most of the cholesterol in your brain was made either in utero or in childhood. Slowly it's replaced, but any little embryo or a fetus that made a lot of brain cholesterol, it's going to last the kid till he's 4 or 5 years old. Now, along the way, the kid will make subtle more amounts to keep that cholesterol in his brain, but no human brain is screaming to the lipoproteins in the plasma, deliver cholesterol, because that's not what they do. So, of course, we don't measure. There are lipoproteins in the brain, but they have nothing to do with the lipoproteins that are circulating in the plasma. The brain makes its own lipoproteins, which are very different than the lipoproteins in our plasma. So most of the discussion that's going to be related to cardiovascular disease is, of course, with the peripheral tissues in the plasma. So every cell in the body needs cholesterol, makes it. The intestine absorbs it, but if it gets absorbed, it goes to the liver as its first pit stop. So the liver is a central organ with a nice pool of cholesterol. So the liver is absolutely capable of distributing cholesterol. If you absorb cholesterol from the gut lumen into your intestine, that intestine is also capable of creating a lipoprotein that can carry lipids. If an intestine makes a lipoprotein, it's released into the lymphatic circulation, but ultimately that connects with the systemic arterial circulation. So lipoproteins coming out of the liver and out of the intestine are an important source of, hey, here we come, we're lipid delivery trucks, who needs lipids? So as it turns out, almost no cell in your body needs a delivery of cholesterol. Why? Because the cells make all the cholesterol they need. Because of what we're eating and putting in our cells, too many cells make too much darn cholesterol. So the biggest function of cells is, God, we got too much cholesterol, I got to evict it. But if you have circulating lipoproteins, you have a wonderful place for a cell to evict unneeded cholesterol. So everybody thinks you have to deliver cholesterol to your cells. Almost under no circumstances. Yes, it can happen. It's a backup delivery system of cholesterol if some tissue needs it. Every cell can express the type of receptor that'll grab a lipoprotein and internalize it into the cell. People think, oh, God, my adrenal gland needs delivery of cholesterol to develop adrenocortical hormones. My gonads need delivery of cholesterol to make reproductive hormones. And if we don't have cholesterol floating around the plasma, God, you'll have hypogonadism and you'll have hypoadrenalism, and that's bad news. Guess what? There are any number of circumstances where people's LDL cholesterol is 5 to 10 to 15 to 20. They have no adrenal dysfunction, no gonadal dysfunction. They make all the hormones they want. So this fear that, oh, I don't ever want to lower cholesterol in the blood because I'll screw up those organs is moronic. It's absurd. And we have to get away from that because that belief has made people so unaggressive at lowering cholesterol concentrations in the blood because they think they're hurting some other organ. You can't hurt the brain because the brain is making all you need. You can't hurt the adrenal gland. You can't hurt the gonads, whatever you're doing to the amount of lipids circulating in your plasma. So to continue the lipoprotein, well, the lipoproteins that the liver and the intestine makes, if you want to understand, I guess, lipoprotein classification, they were first discovered in an electrophoretic system, which separated. Before 1940, everybody thought cholesterol just floating around your blood, like glucose does, or other water, like electrolytes do. They don't need a carrier. And we thought cholesterol could just circulate in the blood too. But it became obvious when they developed a technique that could separate proteins and electrophoresis, cathode, anode. Every protein, every whatever has a surface electrical charge. And between a negative and a plus charge, depending on any molecule's charge, it will migrate in an electrophoretic field. So in 1940, they discovered, almost all the cholesterol in the blood is attached to a couple of proteins. There's a little bit on albumin, which is our most, the largest protein, or the highest concentration protein we have in the blood. So it can carry a little bit of cholesterol, but they noticed that almost all of the cholesterol was on two other types of proteins, beta proteins and alpha proteins. They noticed that gamma proteins, gamma globulins, carried no cholesterol. So now all you had to figure out is what is a beta protein and an alpha protein. Subsequent to that, and they did say, but of the alpha and the beta, almost all the cholesterol is with the betas, a lot less with the alpha proteins. In a moment, we're going to tell you what those proteins are. But about 10 years later, a physicist named John Goffman had ultracentrifugation as one of his tools to separate radioactive elements. And one day, he just stuck some serum in his ultracentrifuge. And, if you spin something, everything separates by its density in a centrifuge tube. Some things flow, low or very low density. Some things sink, high density. So, and he noticed that I see different layers here. And in all of those layers that are separating by their density, they all carry cholesterol. And hence came the names. The ones that sink to the bottom were very high density lipoproteins. The ones that floated on the top were called very low density lipoproteins. And the ones that were in the middle were called low density lipoproteins. And what makes a lipoprotein float or sink? Yes, it's density, but what controls density or buoyancy? The more lipids you have in a particle, it'll float. It will not be very dense. If you have a lipoprotein that carries very little lipids, it's probably carrying a lot of proteins, it will sink to the bottom. So in an indirect way, I just taught you HDLs, which turn out to contain that alpha protein discovered 10 years there. Yes, they carry cholesterol, but not that much. But look at these beta guys, which turned out to be the LDLs and the VLDLs. That is where the bulk of the cholesterol in plasma is in, low density and very low density lipoproteins. They turned out to be the beta proteins. So right away we knew there has to be a protein on the VLDLs and LDLs that are enwrapping it, and there had to be a different protein on the HDLs that are enwrapping it. Go down the road 10 more years and they discover, aha, these things are called apoproteins or apolipoproteins. And the ones enwrapping LDLs and VLDLs are the ApoB. Sort of goes with beta, ApoB containing lipoproteins, whereas the proteins enwrapping and giving structure to the HDLs, the alpha are alpha proteins. They're called apoprotein capital A-1, either an Arabic 1 or a Roman number 1, whatever you want. So right away, we basically have two families of lipoproteins, the ApoB containing particles and the ApoA1 containing particles. HDLs in one group and all the ApoB dump trucks in the other group, which turn out to be VLDLs, LDLs. The intestinally produced ApoB particle is called a chylomicron. It's so humongous and so full of fat, it actually floats and doesn't sink at all in the centrifuge. But that's a very transient lipoprotein that is not measured in clinical practice. So you have the beta lipoproteins and the alpha lipoproteins. Here's the long story made short. The only particles that can crash your artery wall, get entrapped, and generate plaque are the ApoB containing lipoproteins. Wow. So now we know the cause of atherosclerosis. Well, you could say, Tom, it's the cholesterol that causes it. Yes, but there'd be no cholesterol in your artery wall unless an ApoB particle delivers it there. Because of the simple, thank God, feature that every one of those ApoB particles only contains one molecule of apolipoprotein B. If we as clinicians ask a laboratory to measure ApoB and give me its concentration, you are counting the ApoB particle population. And we now know that the number one factor that makes an ApoB particle leave plasma and enter the artery wall is particle number. So if we just measured ApoB on everybody, and because we have known reference ranges and risk ranges, we know when your ApoB, meaning your LDL and VLDL particle concentration, exceeds a certain amount, the odds are damn good that particle is entering your artery wall. Now, atherogenesis is a slow process. It takes decades to develop, but it can't develop if you don't let ApoB particles enter the arterial wall. So that's the story. And the final thing, and we'll talk more about it, if you look at the ApoB families as the potential atherogenic particles, because not every ApoB particle enters the artery wall, most of them just return to the liver or intestine and get cleared. So, but it's particle number that makes them crash.
Thanks a lot for listening to the podcast. I hope you enjoyed it. Dr. Tom Dayspring is truly a national treasure and explains such a complex topic so simply. Stay tuned for our next episodes where we talk about the different types of heart medication and strategies you can use to reduce your risk of heart disease. If you would like to support the podcast, please give me a follow on Twitter and Instagram. You could also leave a review on Apple Podcasts with an honest opinion of what you think. Take care and remember to keep on living every day like it's your last.